Hello, ma'am.
Hi,
Hi. How are you?
I'm good. How are you?
Good, good, good. So we'll just check before starting. Actually, we will start at 8:05,
Okay.
and before that, we'll just check that technicalities if whether your videos are playing or not.
Okay. Do I have permission to share
Yes.
screen?
Yeah.
Okay. So let's see.
Hello,
Um,
ma'am.
Hi. Okay. Okay.
Yeah,
Do you see it?
yeah, the presentation is there.
Okay, except I can't see anybody on screen now. So hold on 1 second. I'm going to try one more thing. Yeah. Now I can see people. Okay. Do you want me to
Ju-
go over some of the videos?
just a minute, ma'am, just a minute.
Sure.
Yeah, so
Yes.
yeah, now videos.
Okay, I'm going to get to the slide which has videos,
Okay,
just so we're not giving away the whole, because I see people have already joined in and are very,
yeah, yeah,
so, yes. Okay, hold on. Now I'll come back to Zoom. And then I will share from there. Okay. Thanks.
uh, it's black only. Is it playing at your end?
No, it went black for me as well. Okay, let's play from here. Okay, let's see this one. Nope. And it all went black. Uh, okay, very interesting. That has never happened before. Um,
So, do you have these videos outside the presentation?
yes, I do.
Yeah, can we try that?
Okay, 1 second. Okay, let me share that now. Do you see it?
Yes. Yeah, it's playing.
Just have to go out of the presentation and do it. All right. We'll,
Shaunak and Niva.
yeah, yeah. I chose them for a reason.
Yeah, I got it.
Okay, I have one more video actually in the presentation. Let me see if that one's also playing, or I'll have to open that one and keep. Just give me a moment. Okay. Mm, is this playing? No, this one's also
No,
going.
same. Yeah, it's
Okay, I will open that up also. Very odd because I do presentations and with videos all the time.
maybe some issue with my Zoom or I don't know.
No, I don't know.
Let me
And
check
it's
that.
playing in the presentation. It was playing in the presentation.
Okay.
Anyway, it's technology.
Yeah.
So now this video has gone sideways. Hold on 1 second.
Yeah.
Okay, now one's open. Second one's open. Third one's open. Fourth one's open. Okay. Okay. I'll go back to the beginning of the slide, and should I just start sharing it?
Yeah.
Hmm. Okay. And Ganesh, just checking, people can type in the chat boxes, right?
Yeah. But actually, generally, whenever we ask question, keep question and answers, no, I generally ask them to unmute and ask the question.
No, that's
Because
okay.
what happened, no? Yeah, because what happened, no, means the question is whenever they type in the chat box, it is a half question or only one part of that thing. And before answering, we should know everything about that child. Mostly people ask about the any case or something.
Right.
So it became like chaos sometimes.
That's okay.
It's better to
I'm looking forward to some chaos here.
no, no,
I
no.
want to keep it interactive.
Yeah, yeah.
So yeah, it
Yeah, we
won't,
will if you want to keep it interactive, that is fine. Like
yeah,
if you are asking something and they are supposed to answer, that is fine.
yeah,
But
yeah.
at the
That's
time of question and answer, at the end of the
yeah, yeah.
session,
No, at the
it
time
will
of
become a
question
little
and answer,
difficult.
they will be unmuting, yes.
Yeah, yeah. Otherwise, you can keep session interactive.
Sounds good.
So we'll start in one. Actually, it's 8:05, I guess.
Okay.
So we'll start.
Okay. Should I just go ahead?
So no, let me introduce you first.
Okay.
So, good evening, everyone. It is my absolute pleasure to welcome our distinguished guest speaker today, Dr. Chola Bidyani, ma'am. Dr. Bidyani is a highly accomplished occupational therapist with over 24 years of experience. She is the founder and director of Reach Therapy Center for Children, established in 2011. She holds a professional master's degree in occupational therapy from the University of Illinois at Chicago and is certified in community-based intervention. Her expertise spans across multiple specialized areas. She is a sensory integration certified therapist, a neurodevelopmental therapist, and is trained in therapeutic listening, handwriting without tears, oromotor interventions, among several other approaches. Over the years, she has practiced in diverse settings, including early intervention, outpatient clinic, and school-based programs, both in the US and India. Beyond clinical work, Dr. Bidyani is deeply committed to building inclusive and aware communities, especially for the individuals with invisible conditions such as ASD, ADHD, learning disability, and other developmental challenges. She has conducted over 200 trainings for school leaders, teachers, and parents, and currently consults with international schools, including the American School of Bombay and the American International School Dhaka. Her impact is global, having supported and empowered more than 1,200 families across 23 countries. Please join me in giving a warm virtual welcome to Dr. Chola Bidyani, who will be sharing her rich expertise and insights. Thank you for accepting our invitation, and the forum is yours. Please continue.
Thank you so much, Ganesh. Thank you for inviting me and thank you for that lovely introduction. And welcome everybody. I know it is Saturday night and it's a weekend and still y'all are here instead of out celebrating the weekend. So I'm happy to have you here and hopefully we will all my hope is to make this a conversation rather than a one-sided talk. And I know most of you are off screen, but I'm hoping that most of you can chat in and make it as interactive as we can. If yes, then please give me thumbs up and let's start with the interaction already. Um, let's see some thumbs up, guys. Okay, I see a few. Thank you. Thank you. Okay, what I would love for you guys to do as I start introducing the first slide is I would want you to write your names. I'm guessing there is a varied experience in the audience that we have. I know we have many esteemed people here, and we have many of the people that I already do know, and some that I don't. but I would love it if you can start by writing your name of who's there and how many years of experience you have. Okay, so as you're doing that, Ganesh, my chat is interestingly going to pop up or not. I don't know, but you will tell me if there are answers or if there are questions. Will you help me out with that?
Yeah.
Yes.
Yeah,
Okay.
it's getting.
Okay.
Did you see that answer message?
Yes, yes, I did. I
Yeah,
did.
okay, great.
Okay, lovely. So now I have the chat box open as well. Lovely. We have people from Nagpur. We have some other people locally. That's awesome. And Ganesh, this is thanks to you. We have impact all over India, and we can do so much exchange of information. And my whole, I was thrilled when you called me because when we talk about things together, I can have an impact on the 50 or 100 people that are here today, and they can have an impact on all the 50 or 100 people on their caseload and their clientele. And it's such a, it's going to be a spider web of just changes happening all over the place, which is why I was absolutely thrilled to be here. Anyway, my hope today is to talk about autism and the advances in autism and how, where things were at and where things are at now. With that in mind, I will jump straight in. Uh, okay, so we want to talk about unmasking autism, and we want to talk about today moving beyond the outdated myths to evidence-based practice, which is neurodiversity affirming. If you all have heard the word neurodiversity affirming, please put a thumbs up in the chat box. Guys, do it in the chat box because I can see the chat box. I can't see your individual screens. Today, I'm hoping that we can challenge each other. It might be a little uncomfortable in terms of what we discussed today because we are going to talk about what is current, what is evidence based, and this might be different from what you already know and what you're already doing, which means that we might have to all open up our minds a little bit. And it's a little unsettling, right? When we hear something from a different point of view, or we hear something that we don't already do, and somebody's saying, oh, this is now the way things are done. So let's keep that aside, and hopefully, again, like I said, it's going to be a conversation more than me talking at you all. um okay, so hopefully by the end of today we want to be able to distinguish between what is old and what is current in the autism world. What is the current evidence-based practice? Second, we want to identify what autism looks like in girls versus what autism looks like in boys and in individuals across different contexts. How many of you here have worked with autism in girls? If yes, again, just put a thumbs up in the chat box, guys. Um, so we want to be able to understand how they may present differently and what are the commonalities as well as what are the differences. Number three, and one of the most important things that I want to talk about today, and you may or may not be familiar with this term, but I want to talk about masking. And I want to talk about compensatory strategies that children and adults on the autism spectrum employ in order to be able to fit in, because it is not a neurodiversity affirming world in general. um, Even now, even with everything that we know about autism, even with everything that we know about neurodiversity. So I do want to talk about masking. Again, in the chat box, guys, if you have not heard the term masking, type masking in the chat box. If you've not heard of the term masking, if you have heard, do not type anything. Then I'm going to be super pleased. And I know that I don't have to spend too much time on that. Um, Okay. The other bit that I want to talk about is how can we as therapists, and we talk a lot about ourselves as means of therapeutic intervention, right? So how can we use ourselves as a therapeutic tool in order to transform parent conversations using strength-based approaches, as well as educate them to do what is current, what is evidence based, and what is growth based for their children. Okay. And then hopefully that translates into different intervention approaches than what you already know but ones that honor authentic autistic traits. And I know some of you, when I said autistic, I know some of you are going to say, oh, but isn't it people with autism and isn't it with individuals with autism? But just like the deaf community, the autism community has also come out and said that we'd rather be called autistic than an individual with autism or than a person with autism. Of course, there are some people that still feel like why when they're called autistic, then that means they're looked down upon. So the number one thing I say to people is if you're talking to an adult who's on the autism spectrum, just ask them, are you autistic? Do you want to be called autistic? Do you want to be called a person on the autism spectrum? Most of them will tell you, call us by our names, and that's good enough. So there's something to think about. Okay, so let's jump straight into the myths, what we used to think and what we do know now. Largely, the perception was that autism is a male condition where it was a 4:1 ratio between boys and girls. Now we know that autism occurs across all genders, male as well as female. And in fact, Tony Atwood's research also says it's a 1:2 ratio. Some other research says it's a 1:1 ratio. It still might not appear like this is the ratio because girls still do not get diagnosed as much as the boys do. And we'll go into when we talk about autism in girls, we'll talk about why that is. Okay. What we used to think is autism must be diagnosed by the age of 3 to be real. But now we know that late diagnosis is common, especially in girls and women. And not just in girls and women, now that the understanding of autism is increasing, I know a 52-year-old that was diagnosed with autism a few months ago, a male, 52-year-old male. And that is now becoming more and more common. Also, autism in girls that are adult women is becoming more and more common as our understanding of autism is growing. Let's look at the next one. High functioning versus low functioning. Now, this used to be a classification, right, at one point in time. But we know that that is not necessarily entirely true to classify people as high functioning and low functioning. So now there are tiers of support or levels of support, right? So somebody that needs a level 1 support, which is they're largely functional, largely communicative, but may need some help with social interaction. Then comes the level 2 second tier of support, or then comes the level 3, which is when there are children who are largely non-verbal or non-speaking. I don't want to say non-verbal, they're non-speaking, and they may have intellectual disability to go along with it, and they may be dependent on their caregivers for their daily life skills as well. However, even within the high functioning, even within the level 1 and the level 2, the support needs can fluctuate and are context dependent. So, for example, you can have a student or a client who is great at academics and so is high functioning, so to speak, in academics, and yet is low functioning in executive function capabilities such as time management, organizing themselves, managing their daily routines. I cannot tell you how many autistic individuals that I have worked with that are high functioning and then leave home and then to go to college or to go to university or go live in a residential facility and come back within a few weeks. And they're extremely capable, extremely intelligent, extremely high functioning, and yet cannot take care of their daily needs, such as hygiene, such as managing their food, and therefore end up being diagnosed with anxiety, depression, cannot continue to live in that environment, develop eating disorders, many other things, and then have ended up coming back home. And this is several instances that have happened. The next myth, what we used to think, is focus on deficits and compliance. Or next, what we used to think, not just myth, was that there was a focus on deficits and compliance trainings, which is when there was a huge push by developmental pediatricians, by doctors, by the autism parents as well for ABA at one point in time. And I know what I'm going to say is controversial and is still controversial, but the more you talk to people with autism that are now adults, the more you see research, the more you see the long-term impact of the compliance-based methods, the more you know that that's not working for them. And so now more and more we have come to recognize that autistic traits are neurological differences and not deficits. And that's something to think about. A lot of us, even as OTs, still go with the frame of mind that let's help this child by fixing them or by building their skill. And we end up doing compliance training. But here's you get a token, you get a reward, you get a candy, you get something, right? And that is still compliance training. I had once, just talking about this and how much of an impact it has even on me as a therapist, how much worry and anxiety it causes me. I had a family that had come to me a few years ago that went to a speech therapist, not an ABA therapist, went to a speech therapist who was a big believer of compliance training. And this child, who was 6 years old at the time, the parents came in very disturbed and upset because this child would go in therapy and the child would be tied down to the chair, and the child was not exactly completely nonverbal, so and could explain basic functional needs like going to the washroom or asking for water or things like that, and yet had some stimming and self-regulatory behaviors which did not go down well with the therapist. And the therapist would say stop, and the child couldn't help it, right? And there was one of those days where they got into this conflict, and this child wanted to go to the washroom. And the therapist said, if you don't stop, I'm not going to let you go to the washroom. And had peeing potty accidents right there in the therapy session, not because of lack of communication, but because it was a compliance based method. And this was not one occasion the parents came and told me, it would happen often. So think about, we as therapists, what impact we have when we, and I know this is an extreme example, but think of what impact we have when we work with a compliance-based approach. Okay. The other big one that really gets me, that still a lot of parents, still a lot of educators, still a lot of therapists insist on, is you have to give me eye contact. You have to look at me when you talk to me. Guys, no. And if you're a therapist that's already understanding why not, so much the more power for you. But if you're one of those that still feels like, but they have to look at us when they're talking to us, here's why not. Uh, a lot of autistic individuals, and again, research is also supporting that. But when you read the accounts by autistic individuals who have gone ahead to write books, write articles, advocate for themselves on social media, they will tell you that when we have to look at you and speak or have a conversation with you, it is physically painful for us. It hurts. And when they say it hurts, it's not just a feeling that I'm hurt or I'm sad or I'm upset. It is a physical sensation. So when we are asking them to look at you, think of what you're actually asking them to do. Or when the parents are asking them to look at them, think of what they're actually doing. And the other bit is when they are looking at you, their processing abilities actually go down. They are not able to simultaneously process information and respond verbally, or process information and do what they're expected to do if they're also expected to look at you at the same time. And also, we know now that multiple forms of social communication exist, right? It could be verbal, it could be gestures, it could be gestalts. Guys, if you're familiar with gestalt processing and gestalt language, please put a thumbs up in the chat box. In the chat box, not on your screens, because I can't see your individual screens. And if not, then I know I can expand on that in a little bit as we go on. So if you want me to expand, say expand in the chat box. Okay. So we know that there are Gestalt speakers And that is also a way of communication. The other bit of communication that really, really works is AACs, or alternative assistive communication devices. Yes, I will expand in just a minute. Let me just finish this thought, and I'm coming back to gestalt processing. Lots of people writing expand in the chat box. Okay, so AACs like Avaz, AACs like Proloco to Go, there are tons of options out there. Now, again, we know multiple forms of social communication exist, but there is still a huge resistance from parents to use these devices or to use these methods of alternative communication. Because a lot of parents falsely believe, and sometimes this is even told by speech therapists to them, that when you use an AAC such as Avaz or another one of those, that your child will never speak. But if you insist that they speak, then they will end up using words. Guys, completely not true. Research shows that with the use of an assistive device, whether it's low tech or high tech, so whether it's picture exchange communication system or whether it's a program like Avaz, when they use more of it, they're actually more likely to gain verbal skills than not. So this is another myth that really just needs to be out of the window at this point. Coming back to gestalt processing, a lot of you have said, please expand. So gestalt processing is when children on the autism spectrum speak or process speech in complete sentences or in complete forms. So to give you a simple example, how many of you have kids that watch a certain cartoon, let's say Peppa Pig, on TV, right? And then they will take a sentence that they have seen in Peppa Pig, and they've come to you, and you're doing your sensory integration therapy or you're doing your occupational therapy in your clinic or in your school or wherever you're working, and you have said, let's sit on the ball, and then they will say in a Peppa Pig voice, or they will say the Peppa Pig line, that but George, the ball is too shaky. That's actually there, and they might have heard it in the Peppa Pig. That's actually their way of taking that language as a gestalt, as a whole, right? And applying it to this situation to tell you that the ball is shaky and I'm actually afraid to get on it. So this is just a very simple example of gestalt processing. It has multiple steps and multiple levels. And guys, read up on it more, because I do want to move on. We're just still on slide number 3. And Ganesh, what time do we have to end?
It's up to you, ma'am.
Okay.
Generally, we keep it for 45 minutes, but it's up to you. You
Okay,
can
all right.
continue.
Okay, so that in a nutshell is what gestalt processing is. It's whole processing from a different context or a different situation, which they apply to that situation. I had one kid that had come to me from Pune many years ago, before gestalt processing was even a thing, right? And one of the autism therapists that was working in Pune referred them to us to come to Bombay. And what I noticed, that every time I would ask the child to do a vestibular challenge, this child in a loud voice would start singing a song with a smile on his face. And it would be a different song each time, but it would be a song, and it would be with that smile. And when I looked back and analyzed that session, I was like, wait, this child did this every single time. Again, the child was applying the gestalt of a happy song to the situation of I am under responsive to vestibular input. And therefore, every time you give me vestibular input, I'm going to tell you I'm happy by singing a song. And that is what the child learned to do, because the child had no other language that he could use. Again, not completely a non-speaking child, had obviously was singing songs, right? So had some language, but still had to apply that gestalt in that situation. Okay, the other big one, stimming should be stopped. Um, how many of you here in this chat completely disagree with this? Put a disagree in the chat box if you say disagree. I'm going to wait for 30 seconds for this one. Okay, so you're disagreeing that stimming should be stopped. Okay, all right. And so you're agreeing that stimming should not be stopped, just to make it clear. Yeah. A lot of parents still come to us saying, my daughter, when she goes to school, she is constantly rocking herself back and forth and she's constantly flapping her hands, right? Um, and we always say this. So somebody has written needs to be functional if possible. Now, I'm going to add to that that stimming is always functional for the autistic individual. Why? Because it helps with very, very important function of self-regulation. Again, if you read accounts of people that are on the autism spectrum, they will tell you that it is not something that they can help. It is not something that they do intentionally. And it is not something that they can stop. In fact, they say that we feel a kind of a physical release of energy and a sense of calmness right after we stim. Um, okay, so somebody said stimming for social, yeah, it can be functional, needs to be functional if possible for social acceptance. Sure, maybe if the child is at that point or if the adult is at that point. But if not, and if a replacement is not going to work, we still say that that's something that is self-regulatory in nature, and we are not going to take away a means of self-regulation from this child. We can explore other options and other strategies that may provide the same sense of self-regulation, but we're not going to say to a child, stop flapping, ever, because it is important for them to have that means of self-expression and self-regulation. Yes, we're going to front load their systems with sensory inputs so that their need for self-regulation goes down in that manner with that intensity. But we as therapists will never say don't stem or don't flap. um, and the stimming can occur in different ways, right? So again, here are some, right in the beginning of our presentation, I've raised some challenging thoughts, which I know some people are going to disagree with. But this is where things are at the world over. Yeah. Somebody's written, I think it's time for society to understand, accept, and allow them to regulate self to participate better. And that is exactly what we're here to do as therapists, to help them participate better, to help them access opportunities which were not open to them so far. And even now, a lot of opportunities are not open to individuals on the autism spectrum. So it's our job to educate the parents, to educate the teachers that work with them, that if they're not looking at you, this is why they're not looking at you while they're talking to you. If they are singing a song which they've heard somewhere else in this context, this is why they're doing it. They're actually trying to communicate with you. If they're stimming during a certain, lecture, or during a certain talk, or during a certain session every single time, there's a reason why they're doing that, because maybe that's causing anxiety. Maybe that's a place where they need to self-regulate consistently. If stimming is harmful, like hitting themselves, then obviously our first job is to keep them safe. In that case, we would find another. I find that stimming is not, hitting is generally a response to something else that has happened, especially if it is a non-speaking child, right? So if you dig deeper, you will see that a stim is a hitting is not always necessarily a stim. So I'll give you an example. We have a completely nonverbal child. She's a girl, and she is a severely impacted girl on the autism spectrum. She's about 9 years of age, and she goes to a special school. The parents think she is stimming, However, she is a highly bright and intelligent child. And she also hits. She hits herself and she hits them. But the only time she does it is when things have not gone as per the predictable routine, or things have not gone which she was told that that's how they're going to go, or she's had consistent sensory inputs which are strenuous to her sensory system through the day in small spurts, and then she falls apart at the end of the day and starts stimming or hitting, actually. But it is identified as a stim in school because she is doing it and she's doing it often. So when it is something like hitting, we have to look at what is happening in the background. Uh, just today, I had a family that came to me from Ahmedabad. And the family said to me, our child is stimming and he's hitting us and hitting himself. And his stim is to keep watching Peppa Pig. And I said, but what other stimulation does he have? What else is going on? So this is an only child. Does not go to school. Non-verbal child, so schools did not accept him. They're from a interior part near Ahmedabad, so did not have schools which were taking him in. And he sits in front of TV, and when the TV is taken away, then there is hitting or there is stimming. So again, what is the reason that that's happening? A, he does not have enough other stimuli to keep him cognitively engaged. B, it's just easy for the parents as well at this point to keep him engaged through the TV. And C, he's gotten to that point where if he doesn't get it, it's the dopamine hit is not coming as often as it needs to. So what appears as a stim could actually be something else. So just something to think about, guys, when there is hitting that is being noticed as a stim. A lot of times, if it's a non-speaking individual, hitting also is, and it gets really often missed in autistic individuals when there's a physical symptom, when there's stomachache, toothache, something going on internally, and it gets missed quite often, unfortunately, because they are not able to express. Yeah. So there you go. There you've written, child had started hitting herself for getting attention. So we know why the hitting is, right? Anyway, so what I was saying was that when there is pain, when there is physical pain, it can appear as hitting because again, they have no other way of expressing themselves, and it happens very often. So something else to think about. The very first question that I ask parents when they come to me is your child in pain? Is he going to fall? Is he unwell? Is he recovering from something? Is he coming down with something? That's the very first question we often ask. Okay, moving on. All right. So autism in girls, right? In girls, we see that a lot of the behaviors are internalized rather than external. In boys, you will see hyperactivity. In boys, you will see a lot more stims. You also see stims in girls, but they look a little different. You may see a lot of verbal stimming in boys much more than in girls, right? Girls do tend to learn social imitation and masking quite early. They learn to fit in quite early with the other peers. They may have different special interests than boys do. Their sensory seeking is quieter. Like I said, it's more internal stimming, and their stimming might be more with their thoughts rather than an external stim that you may see in boys. They also learn to please people quite early in life. And they're also much more compliant, and which again, with research and with enough number of women being diagnosed as they get older, what we see is more often than not they have initially been diagnosed as either having depression or having anxiety, or in many cases even having ADHD, before eventually, after many visits to many neurologists, many psychiatrists, eventually they do get the diagnosis of autism. I have this little girl. I had this little girl who I was working with when she was in school, and she was going to a regular international school, about a 10-year-old. And she would make friends and had a few close friends. But every few weeks, there would be something that would occur in terms of friendships, because while they're different presentation than boys, they still do see the world as black and white. So the person did not do this, therefore I'm not their friend, or the person did not do this, therefore they are not my friend. They don't get me, why should I be their friend, right? There's also a huge correlation of perfectionism with girls, especially around social rules, which is why friendships then become difficult. There could be selective mutism in certain contexts. So, just 4 weeks ago, I got this little child from Bombay going to a certain school and would go to school every day and not say a single word. The parents brought her to us in the assessment session, did not say a single word for the first half an hour. And then I brought a little doll and I started talking to the doll and playing to the doll. And I just started keeping things like necklaces and earrings and, pretend play things like that in front of her without really saying anything. And then eventually she started opening up and talking to me. And parents said that doesn't really happen. But now this girl is in a different school and absolutely blossoming, talking, engaging. It's still hard. Social communication is still hard, but we don't see that selective mutism that was seen in that school where there was high pressure on academics, high pressure on performance, high pressure on participation. Eating disorders are again commonly seen in girls specifically, and specifically when they're older, much more so than boys. And here again, a huge deal of masking in girls, especially, and it's covered up because they may have advanced verbal skills or they may have advanced reading skills. And academically, they may be, the first, second, third rankers in class, maybe. But that really helps with their ability to mask. So I was talking about this girl in 10th, that is a 10-year-old, and so would perform fine, the one that had issues with friendships, right? I just mentioned her a little while ago. She would be absolutely fine through the school day, no meltdowns, nothing that would cause any concern for teachers. But that she would go home every day, and 6 o'clock to 9 o'clock, she would shut the door. This is a 10-year-old girl, okay? She would shut the door and all she would do is pace. She'd put her headphones on and she would pace in her room for 3 hours straight. She did not have a diagnosis of autism when I first started seeing her. Guess what happened in a year? She got the diagnosis of autism. Um, the other thing that you see in girls is emotional dysregulation. Again, it does not appear as meltdowns or tantrums. What they may appear as, oh, suddenly she's talking to us, suddenly she's not. What is up with her? That's what you may see, especially with the ones that are verbal, right? You may see emotional dysregulation in non-speaking girls, which then can come across as the girl is coming and biting or the girl is coming and hitting, if they are at that level of functioning. Okay, where are we? Okay, let's talk about autism in boys. So, traditional view of autism in boys has focused on obvious repetitive behaviors, clear communication delays, aggressive and disruptive behaviors, and very, very specific interest. Trains, planets, airplanes are very common ones. Of course, there are multiple ones. What you also see in boys is that the interests keep shifting. It'll be 6 months of trains. The next 6 months will be airplanes. The next 6 months will be planets. The next 6 months will be something else. Um, I had, I have an individual who is now 22 years old and has just secured admission in Cornell University. But he would be what we would call, in the traditional sense, a high functioning autistic person. But he had so much trouble in school. He first came to me when he was in sixth grade, in sixth standard. And then since then, he's gone to win a competition by NASA. He is finished IIT with honors, and now he's doing masters at Cornell University. But when he was younger, when he first came to me, he could not get over the fact that why is you, how many of you are old enough to remember the terrorist attack on the Taj Mahal and Kasab, right? Do you guys remember that? Yeah. So, at that time, I think he was put in the Yerwada jail. And this chap that I'm talking about used to live in Pune at that time. And so when he first came to me, he could not get over the fact that, but he has killed so many people, and why is he still alive? His first conversation with me for an hour and a half was on why is Kasab still alive? And there was no way that I could get him to move beyond that conversation. What was happening in school is he was being teased, he was being bullied, he was picking up benches and throwing it at other children. He could not stand the smell of food during lunchtime. And so anybody would come near him and he would push them and shove them. And he had the hardest time until we figured out that he has autism, and he has autism with sensory modulation challenges. Obviously, very bright, right? Won a gold award, gold medal with NASA, gone to IIT, gone to Cornell. So super, super intelligent, almost like our quintessential Sheldon, right? Uh, so similar to that, but had the hardest time, and again, doesn't fit in your traditional sense of autism in boys, but you can have somebody like that as well. Okay, so masking exists in boys as well. So why was that child that I just described, who's now 22-year-old adult, not diagnosed until 12? Because of masking. Highly verbal, highly intelligent, could have a conversation with anybody on any topic, but really real challenges with black and white thinking, real challenges with flexibility, real challenges with sensory modulation. Okay, emotional vulnerability is often misread as behavioral challenges. How many of you have students that are verbal and that will come to you, and when you say something, it's okay, I don't care? Do they really not care? Or is that something that they are doing to protect their own self and self-esteem? Just something to think about. Social desires with skill gaps leading to rejection. Now, all of these kids that I started seeing when they were 2 and 3 year olds are now teenagers and adolescent boys. And the gap between these teenage adolescent boys and a neurotypical individual is so wide. And yet, these are adolescents with needs, desires, the same physiological changes that somebody with neurotypicality goes through, they also go through. However, huge challenges with depression because they cannot and do not find opportunities to fulfill those social desires, whether it's with other boys or whether it's with other girls, right? So, huge challenges with self esteem there. Again, sensory needs expressed as hyperactivity or defiance. I already mentioned the boy that went to Cornell. Executive functional challenges impacting all areas. Another student, this was again a family from Pune, a different family that I mentioned, that the child went to, that adult, 17, 18-year-old, went to college in another city and came back in a few weeks because could not manage routines, could not manage acquiring food to eat for himself. So starved for 4 weeks and then cried and came back home. Not because food was not available, food was there. He couldn't figure out when is the time to eat and how do I get my food. That was the challenge. Okay, and then late diagnosis happens when academic and social demands increase. Like I said, the 12-year-old, highly intelligent, highly verbal. Okay. So, what is masking? And this is something you will see often. Masking is conscious or unconscious suppression of autistic behaviors while adopting neurotypical appearing responses. So, for those individuals that stop stimming or that we want them to stop stimming, that is actually masking. Trying to fit in without looking weird or different or abnormal. That is masking. And unfortunately, as a lot of you said, society does demand it of them. Sometimes their own parents demand it of them. And it's our job to help the parents understand how much damage and how much harm that is causing. Okay. Let's talk about sensory processing. We're all OTs here. We all always want to talk about sensory processing, right? So, what is the old model? Is a very clear cut, hyper responsive. We're all very happy that the DSM-5 has included sensory modulation, specifically tactile modulation, auditory modulation, as one of the diagnostic criteria, right? In the DSM-5. What a big win for us. But we also know now that sensory processing is not just as simple as, oh, auditory defensive or tactile defensive. It is much more complex, it is much more dynamic, and it changes with stressors, it changes with context, it changes with the environment. So you can easily have a child that is sensory seeking in certain situations and avoiding in certain other situations. You can easily have a child who loves his own birthday parties but cannot stand other people's birthday parties because he has no control over that situation. Too loud, too crowded. But when it is in his home, his party, can do okay. Can manage the noise, can manage the touch, can manage the people. Um, Context dependent, right? Loud music is okay, but vacuum cleaner is not okay. Again, because loud music could possibly be under the control of that child versus vacuum somebody else is doing, doesn't know how loud it's going to get, doesn't know how close it's going to get. And so that could be a reason why there are changes in sensory processing. Interoception challenges. Now we know more and more about interoception in individuals with autism. All of you OTs that do work with interoception and are familiar with interoception, please put the thumbs up in the chat box, please. All of you are familiar with the term interoception? Okay. So for those of you that are not, a lot of you are. Wonderful. So lovely to see. For those of you that are not, interoception is the understanding, is the eighth sensory system, by the way, and is the understanding of what is going on internally within the body and the ability to verbalize it and tell you about it. Of course, verbal skills are a different matter in somebody with autism. But we find, so when there are interoception challenges, what we have to, as OTs, try to figure out is whether it's truly an interoception challenge, meaning that are they really not understanding the functions of bowel and bladder? Are they really not understanding hunger? Are they really not understanding thirst? Or is it a communication based challenge? That's something else to think about when you have an autistic individual. And the next bit is sensory flooding, leading to shutdown or meltdown. When there is too much stimulus, right? And all they can do is go into a shutdown for that day, for some days, for that period of time, for the next half an hour. It could be different in different individuals. Again, sensory wise, stimming is a means of regulation, not distraction. That is not something that they're doing to get out of the task. That is something that they are doing to actually be able to focus on the task. And the more we think about that, the more you will see that it is true in the children that you are working with. Sensory processing preferences as legitimate accommodations. And that's an easy place to start. I'm going to talk about that a little more. But also for us to know that sensory modulation, specifically auditory as well as tactile, has a huge link, and also vestibular for that matter, has a huge link with anxiety. So when children are in a situation where there is high anxiety, like for example, this was another 14-year-old. This was right after COVID. And the mom came to me saying that he has exams coming up, but he just cannot study. And this was not the case before. And he is not auditory defensive. But now it's the crows outside the window. And every time he hears the crows outside the window, he shuts his ears and goes under the desk. Now, this is Bombay. There are going to be crows outside the window, right? What are you going to do about it? So, when we problem solved, this all started because there was anxiety around examination. So we worked around, of course, we worked around sensory tools like the ear defenders, like put on your own music so that you're not hearing other things. But we had to work backwards and figure out what was the cause of anxiety, which was leading to this auditory modulation challenge, which was not present before. So you might also have to do things like that. Okay, and executive functioning. Again, another very, very dear to heart topic for a lot of us OTs, right? We love to talk about executive functioning, and it is a very important part in all of our lives and autistic individuals' lives, and yet it is the least understood. I think we all understand boys and girls now. We all understand a bit about masking. We all understand a bit about gestalt processing. We definitely understand about sensory processing. But executive functioning is something we all talk about, and yet we don't know how it manifests. But today I've shared a few examples also as we've gone along about how it manifests. Okay, so what are the key areas affected? One is working memory. So holding information while processing. And now remember, we're making demands. Look at us, talk to us, process information, and do your task. Is that going to happen? Not very likely. So we have to break it down for them. The more we make it visual, the less the demand on their working memory, the more they're going to be able to do the task or the sets or series of tasks that we've given them. Cognitive flexibility. We all know that individuals on the autism spectrum may have challenges with transitions and routines. Not all of them do. Some of them do. Some of them may have challenges with all transitions and routines. Some of them may have challenges with only social transitions and routines. And some of them may have challenges only on certain days, but not on all days. But we know that there could be some level of inflexibility. And that is not because they don't want to do something, but that is because there could be a sensory processing challenge. That is because there could be anxiety around a novel situation or a novel person. So, again, the more we help with the flexibility by preparing in advance, the more we can help them navigate society or school or even their home. Inhibitory control, managing impulses and attention. Now, we also know that stimming does get in the way of attention, right? But it is regulatory in nature. And once and you'll see in the videos that I show you what I mean by that. But once the child is more regulated, you're actually going to get more attention, not less. So that's something to think about. Uh, Also, we know now more and more individuals are informally being called as ADHD, which is autism with ADHD. And it's not a formal DSM-5 diagnosis, but a lot of them have autism as well as ADHD. So that is also going to impact their inhibitory control. Planning and organization, breaking down tasks. How do I get my food? If lunch is served between 12 to 12:30, how do I get to the cafeteria by 12 without somebody else telling me? My mom is not here to tell me that I need to get my food at 12. So that planning and organization, time management, estimating, tracking time, and emotional regulation. When I've not gotten food today, am I going to sit and cry that I haven't gotten food? Am I going to be able to get over, regulate myself, and try again tomorrow? Or just because I've not succeeded today, the anxiety is going to be so high tomorrow that I'm not even going to try, which also happens. And this is just an example of eating, but it happens with multiple tasks. Okay, so what can we do as therapists? As I said in the beginning, if we as a group make this change in the parents that we are working with, they're going to in turn make that change. Yes, they are. Yes, there are many aspects to executive functioning, and all of those task initiation, problem solving, impulse control, I already said, attention, I already said, self monitoring as well. They're all also part of executive functioning, and you will see these challenges and they're interrelated, right? So, but I will say one thing, the more you can keep it visual, the more you can break down steps, the more they're able to participate, overcoming the executive functioning difficulties. So that is what I will say. Thank you, Gokul Raja. Okay. So what I said, yes, also using visual schedule. As we make an impact with the parents, they're going to make an impact with their children. And that's how we will see a larger impact on society. So let's practice transforming our language as therapists with the parents that we work with, right? So instead of saying your child has deficits in, what could we say? So I want people to start chatting in the chat box. What could you say? Your child has deficits in. Instead of that, what could be said? What's an asset based, positive, affirming way to say this? Okay, child has difficulty with challenges faced by kid. Your child has following strengths which might help. Your child is facing problem in these areas. Let's see what I've got down. Your child processes information differently, and here's how we can support that. Yeah, and some of you have written something close to that. Okay, going to the next one. We need to fix these behaviors. What could we say instead of that to the parents? We've moved on to the second one, guys. Yeah. Let's explore how we can help this child. Let's work towards this, make them more functional. Okay, let's see what we've got here. These behaviors serve a purpose. Let's understand what your child needs. Yes, somebody's written exactly that. Okay, next one. Your child isn't making eye contact. What's a positive, affirming way of saying this? Do we have people typing in the chat? But he is task oriented. Okay. Okay, any others? All right, let's see what we've written. The avoidance is helpful for processing. Your child shows attention and engagement in their own way. They're processing, and therefore, it may take them some time to look at you. We need to work on compliance. What can we say? We'll help your child develop self-advocacy skills. We'll help your child stop stimming. What can we say instead of that? This should be an easy one. We've talked about stimming quite a bit today. We'll help your child stop stimming. What can we say instead of that? Co-regulate. Perfect. I love co-regulation. Your child is engaging in self-regulatory actions. Let's find out when and why. And let's co-regulate. When you meet the child's energy with your energy, which is calm and regulated, they are going to co-regulate themselves with your help. And that was perfect. Thank you, Amol. Okay, so what do we know and what do we do? Instead of a fix-it approach, what can we do? First, environmental modifications are the easiest to do, right? Which would involve lighting, sound, texture, easy to fix. Lighting is a problem, you can reduce it. Sound is a problem, you can use ear defenders. Texture is a challenge, you can use specific clothes that they wear that they prefer, and that's neurodiversity affirming. Predictable routines with visual supports, really helpful in daily routines, really helpful in therapy, really helpful in routine changes as well. Choice and control over how tasks are completed. So choice boards, guys, are great again for even a non-speaking child because they can easily show, point the picture, pick out the picture, give it to you, and it works well. Break systems and self-regulation tools. Break card is one of my most favorite things to use. When they've had enough, they can pick up the break card and tell you, okay, I've had enough. I had a girl, 3-year-old girl, who would, every time she was dysregulated, tell the mom, I want to go pee pee. And the mom would take her pee pee, and then, of course, she would go to the washroom, stand, waste time, just play with water, and come back out. She was telling us over time, we figured, not the first couple of weeks, over time, we figured she was telling us she's dysregulated with the amount of challenge we're giving her. So we taught her break. We gave her the break card. She started using the break card, and that's a tool she can apply in many different contexts, in many different situations, at home, in school, in therapy, everywhere. So that's something that really works well. And communication support. We've talked about ASCs and visual schedules, right? I'm going to stop sharing this one and share my little video of a visual schedule being used in our therapy session.
First, Trishala is going to tell you a story. Okay? I'm going to tell you a story. We will go through that story. After that, number 2, Neely is going to go on the rocket. And he's going to go and knock the monster. Yes! And we're going to do that for 1, 2, and 3 rounds. After that, Neely's going to go on the mountain and get some fruits for our friends, for Baba, for Mama.
Okay, a very short, simple example of a very, very simple visual schedule. Doesn't need pictures, doesn't need any complicated planning. It's done right then and there. They first made choices, they decided what they were going to do together, and then they drew out the visual schedule. Very easy, right? And a very powerful tool for children to make those choices. Okay, where are we here? All right.
First,
Moving on. Skill building that honors neurodivergence. So when we're therapists, one of the things that we do, of course, environmental, we assess the child, we understand the child's needs, we know where the child is at, we set goals for the child. But also, when we set goals, we're talking essentially about skill building a lot of the times. We're not talking about environmental modification. We're not talking about parent education. Most of our goals as therapists are around skill building. So these are some additional goals. I mean, everybody is used to sensory based goals, everybody is used to gross motor goals, everybody used to fine motor goals. But I would urge you to think about these as some additional goals, right? Self advocacy. I need a break. That's self advocacy. Identifying and communicate. I want to do this, the disc swing first and then the ladder second. That's self advocacy. So identifying those and helping them communicate. Even though you're an OT, even though you're not a speech therapist, there are certainly ways that you can do that. Interoception development. Interoception, very important for self-awareness, for body awareness, close link with proprioception, and a really, really close link with emotional regulation. So that's a goal that we should all start making when we're working with autistic individuals. Executive functioning support, we've named all the executive functions and finding the scaffold that they need or the skill that they need to build in order to achieve that particular executive function, initiation, time management, problem solving, whatever it is, right? And we give them the external scaffold and we teach everybody around them to give them the external scaffold until it becomes internalized for them and they no longer need that external scaffold. Social skills that feel authentic and not teaching them through masking or through compliance. And I'm going to share another example of this just in the next slide, and a lot of you will be familiar with it. And also, we're teaching them emotional regulation, and somebody very rightly said co-regulation. That is the first and the most important way to teach emotional regulation. Okay, going back to my videos. When you see these videos, I'm going to play all three of them back to back. And what I would like you to do is, as you're seeing the videos, I want you to think about what are the strategies that you have seen in these videos. Ganesh is smiling because we share both of these children in therapy. He sees them at school, I see them at the clinic. So that's why he's smiling. They're autistic siblings. The older one is 15 years old now, and the younger one is 9 years old now. And the older one is speaking autistic individual, and the younger one has words but is not as speaking as the parents would like her to be. She is a gestalt processor, by the way. So as you see these three videos, which I'm going to play back to back, I would like you to start putting in the chat box what you have seen us do in these sessions, in this session, which is different, which is neurodiversity affirming, which is taking their strengths into consideration, which is an environmental modification, which is anything different than what you have done so far, right? So I want the chat boxes to be really busy at this point. What I do want to say is this was a session I don't normally see them together. This was a session where I did see them together because they were having a hard time with emotional regulation around each other at home. So the mom wanted me to simulate a playful environment so that she could take those strategies and start using them at home. And you'll see what happened in this session. But I really want you to start typing in the chat what you see as neurodiversity affirming practices. Okay, so I'll start with this one.
How have you been?
I've been amazing.
You've been amazing. How's Neva been?
She's been amazing.
She's asking you to take off your bag. That's what she's asking you to do.
Okay, so that was the first one. Gonna do the second one.
And 4. And again. Kiss कर दो after 10. 5. Catch. Ooh. Okay, leave it. Let her give the kiss. Give the kiss if you want to give the kiss.
Give the hand.
Kiss and then go back. Mwah.
Oh.
Okay. Guys, I'm not seeing anything in the chat box yet, so please start typing if you haven't already. And that's the last video.
We can start with it. Oh, look at that. Oh. Oh. Yeah, tight hug. Squeeze it tight. Yeah. My God.
Okay, so just FYI, the older one had just had knee surgery, which is why he was sitting down through part of the game that they were playing. And the older one and the younger one don't go by each other without one having a meltdown and the other one hitting each other. So this was the first time that this ever happened, just FYI.
How have you been?
Amazing.
You've been amazing. How's Neva been?
Okay, I'm gonna try to go to the next slide.
We can start with it.
Okay, I think I'm gonna have to go to the next slide without. All right. So guys, in the chat box, what are we seeing? Yeah, we're helping them connect and bond with each other. That's what we saw. There was also, the expectation was that she would go till 10, but she wanted to go and kiss him in the middle and hug him in the middle. And we said, that's fine, because guess what would have happened if we would have said, no, you're going to finish 10 and then go. What would she have continued to try doing? Would she have been equally invested, equally attentive in the task? or not. Yes, we would have had behavior, we would have had hitting. She is known to hit and bite as well. Not anymore, but we wouldn't have had engagement. And our only goal in that session was engagement, which was constructive and positive engagement. Okay, so what we're moving away from, to sum it up, we're moving away from compliance-based behavioral interventions. We're moving away from punishment for stimming or other autistic traits. We're moving away from forcing eye contact. We're moving away from one size fits all social skills programs, which now social thinking has received a lot of uh, not so positive feedback, and they have also changed the way that they are conducting their programs and interventions aimed at making children appear normal. So this is one of the ways that we moved away from you need to sit like this, you need to listen like this, you need to do this. Look at the two visuals and see how it is different. And I would suggest, if you can, take a screenshot so you can look at it again at ease and again understand how different things are with the neurodiversity affirming approach. Okay, I'm assuming whoever needed to has taken a screenshot. Okay, and I have case studies, but I think Ganesh, we've kept our audience long enough. So we will move on to how we talk to parents, and then we move on to questions. Okay. We always consider parents as experts. We're going to explain autism as a neurodiversity and not a deficit. A lot of you talked about highlighting the child's strength, and that's what we do as therapists. And actually, this mom, the two children whose video you saw, and I said, I'm doing this workshop today. And is there a message that you would like me to give the therapist? And she said, yes. What you do as therapists, what I do, what all of you do as therapists, the parents watch that and the parents model that at home. And you may do something positive for 1 hour, and the parents are going to exactly copy that at home for 24 hours a day, 7 days a week. Or you may force the child to sit down and say, no, you cannot go to the bathroom until you finish this. And the parents are going to copy that 24 hours a day, 7 days a week. So you as therapists have a lot of power in the messaging that you're giving by your words, by your actions. So this mom wanted me to tell all of you that please be mindful that you are the teacher for the parents. Yes, and you have power and you have responsibility. Okay, so what are we going to do with these? Again, take a screenshot. These are lovely resources. And I've really enjoyed reading The Reasons I Jump. I've really enjoyed reading The 10 Things Every Child with Autism Wishes You Knew. And they're, again, very powerful books. I also use them as parent resources, especially for ones that keep telling me, can you stop my child from stimming? Or can you stop my child from tantruming? Somebody wanted the previous slide. Okay. Yeah. Okay. Can I move on? Okay. And then the next steps, all of you as therapists, whenever the next child with autism comes through your door, I want you to keep this neurodiversity affirming lens and reflect then on the difference in intervention that you have caused because of now what you know in terms of how they process, how they understand information, how they may relay information to you, how they self-regulate, and what can you do to support them through all of these as they're going through life. Okay, and I'm going to stop here. That was a long one.
Yeah, but that was awesome, Miss. It was very insightful. So those who have questions, just unmute yourself and ask the question.
Thank you, Prachi.
I'll go first if everybody's okay with that.
Sure.
Sure. My question was the is there a correlation between age and decrease in the ability of masking, especially in girls with autism? And is that the reason why some of the signs and symptoms are more evident and obvious? And because I'm seeing a senior citizen, she's in her 60s, and she is demonstrating a lot of these behaviors to the point that she had lost weight because she was not able to eat and blah blah blah. So she was a failure to thrive. So I'm trying to figure this out. Is she indeed autistic diagnostic? Is there a diagnosis there? The doctors have not been able to diagnose her. Um, People are pushing her to go to a psychiatrist. The psychiatrists are not available. So it's been a big issue. So I'm just wondering if she might have been masking all these years, and as age, the masking capability is gone, and that is why all of these behaviors are showing up.
So, a couple of things. Of course, I can't comment, exactly for sure, but I can tell you certain factors, right? We do know that masking over time leads to burnout. We do know that masking over time shows up as depression, shows up as anxiety, which is going to manifest in its own way in different individuals, right? The other thing is, if it's an older individual, I don't know if the person is living alone, not living alone. The other bit that happens is nutritional challenges, right? And nutritional deficits. And with that comes its own set of anxiety, its own set of brain fog, its own set of burnout. So again, I don't know if that's a contributing factor. But to answer your question, I don't think that it is to do with age. I think it is to do with the amount of masking that the person has done, and the context change and the environment change, and the demands that keep being placed on that individual. So only you would be able to answer that if you know that person quite closely. I can just tell you these factors are
No,
contributing.
all I was asking is there a research correlating age to decreased in the capability of masking?
I don't think it's related to age.
So when I say burnout, when you were saying burnout, wouldn't burnout be like over a period of time that she has done it for so long? So yes, it is. Wouldn't it be related to age? That's how my logic is working right now. Wouldn't it be related to
No,
age
I mean,
after many years of
yeah. But
masking?
again, it could be for some individuals, it could be after 3 years. For some individual, it could be after 20 years. So what I'm saying is, yes, over a period of time, but still not a direct correlation with age, is what I'm trying to say. You could even have a 15-year-old individual that's having a hard time continuing to mask and not necessarily wait till 60. That's what I'm trying to say.
Sure. And one other quick question is, same thing. Is it the reason why more adulthood related ASD diagnoses are surfacing?
I maybe, but I think it's also what is happening in the last few individuals that I have come across is their children have gotten diagnosed. And then over time, they have thought about it and figured, oh, this is what they have, but this is what I have struggled with all my life. And then a lot of them have self-advocated that this is my challenge as well. So I think it's increased understanding on behalf of the professionals. I think it's increased understanding on behalf of the individuals themselves, which has led to more of the diagnosis being made.
Next question. We'll take only 2 or 3 questions. Okay.
Sounds good. Thank you,
Yeah.
Prachi.
Anyone? Any question? Okay. I think we should conclude now. It's
I'm going
already
to
9.
quickly ask a quick question.
Okay.
Is it possible to make your presentation available, Ms. Bidyani?
Sure. I can send it to so maybe Prachi, you can send your email to Ganesh and I will get it sent to you.
Absolutely. Thank you so much.
Sir, may I have a question?
Yes, absolutely.
Ma'am, sometimes we get to know that parents are hitting their children if they are not well behaved in social gatherings or not well performed in their school or something. They know how to regulate themselves, but they didn't do it continuously. Sometimes they hit. Should it right to hit them or make them understand we shouldn't do that way or something else? How we can counsel the parents not to do that?
Yeah. So this happens more often than we know, and this happens more often than parents admit that they're doing it as well. But it happens.
Yes,
Um,
ma'am.
it's a lot of frustration around their expectations of their child not being met, right? Parents have expectations that my child will go into this social situation and say hi to other people and start playing with other kids and be polite to everybody and, do everything that a neurotypical child does. Or they may have expectations that academically, oh, my child should do this and do that, and when he grows up, they should do this and do that. But what ends up happening is because of the challenges associated with autism, those expectations are not really met, which leads to a lot of frustration with the parents. So I think the number one thing is to start talking to the parents slowly, gradually, gently, but every time you see them, is that this is what your child is good at. This is what your child's strengths are. This is how your child does well. And when you give them the tools, and when they see the tools working, like for example, the visual schedule, very, very powerful tool, right? But a lot of parents think that, oh, but my child knows, why do I need to show it to them visually? But once you tell them why they need to start doing it, and once they start using it, they will see their child in a different light because the child is more successful in these situations. So I think as therapists, we have to help them break it down that yes, this was a struggle, but what can we do to support them? So whether it is a social story, whether it is a visual schedule, I think it's bit by bit, right? It's understanding what works for that child, what works for that family, and what can you do to support that parent? Because we have to understand also that a lot of the parents are traumatized, not because of the child, but because their expectations of who this child would be are, are actually shattered, right? Um, until they start accepting that this is what autism is, this is what my child can do, this is how I can support my child. And then they blossom and the family blossoms. I've seen both ends of the spectrum. So, as a therapist, slowly and gradually, one step at a time, start supporting them.
Thank you, ma'am.
I have a question.
Yes.
This is Gokul.
Yes.
How we can structure a play date in between typical and neurodivergent kid? What are the causations that we have to take, or is there any structured way that helps the both kids to engage in a situation? Yes, it's very difficult for the typical kid to understand the neurodivergent kid.
Yeah.
But what are the causations, or is there any structure that we can follow that helps us with this?
Yeah. So I typically, because of, again, this is not in any textbook, this is not any research study, this is just my personal experience. Because, again, having worked with individuals with children with spectrum over a number of years, I'll just share what has worked for us. What we typically tell parents at our center is start with a play date, only two children, one child yours and one other child, could be a neurotypical child or could be a neurodiverse child, doesn't matter. The idea is socialization, the idea is being together, and the idea is regulating together in the beginning, right? As you saw the siblings do in that video that I shared.
Yes.
So what we say to the parents is keep it very structured, have the parents present. Also, what parents want to do is when there is a play date, they want the children to play and they want to sit and chat with the other parent. And so we tell them, no, don't invite the other parent, just invite the child. Keep the first play date to only 15 minutes. Use a visual schedule. The first 5 minutes, just like how they go to school, right? First 5 minutes is morning meeting or singing a song or something like that. So we say first 5 minutes, sing a song, player passing the passer, or twinkle twinkle, ringer ringer roses, one of those games. Number two, do a simple building game, maybe with Lego blocks or with the large magnet tiles or with something huge, where one has one piece, the other has the other piece. They have to put it together to build that structure together. And number three, have them eat a small snack and say, done. So, what you have done is you've given a visual schedule, you've created predictability, you kept it short, you've kept it structured, and you've achieved success. And then once you've done that a few times, then you can increase the complexity, you can increase the demand. And it doesn't have to be these specific things. I'm just giving examples, right? I mean, it can be something of interest to both children. But the idea is you keep it short, simple. You end with food. If the child is not a picky eater or a fussy eater, it'll work well. And then you keep them going. And once you've done this a few times, you can increase the number of kids, you can increase the duration, you can take it outside of the house, where again, there are more elements of not knowing what is going to happen. But first, keep it structured, keep it predictable, keep it routine.
Sure. Thank you so much.
Hi, can I ask a quick question?
Absolutely.
Yeah. So for kids aged ranging from 5 to 10 years, what's the best way to teach them feeding themselves, dressing, toileting? Any specific strategies that you can recommend?
So, I mean, I can't recommend a specific strategy because you've given a wide range of things, right? Feeding is a whole different skill, dressing is a whole different skill, toileting is a whole different skill. So, if you have a specific question, I can try to answer specifically. But otherwise, I would say, again, keep it visual, keep it routine. So, every day they have to do it at the same time, and use backward chaining. It works really well for dressing, bathing kind of things. For eating, again, if they know eventually somebody is going to feed them, they are not going to feed themselves. So, and we have so many children that eat independently in school, but will never, ever, ever eat at home because they're just used to the idea of being fed. So, again, these are very generic examples and generic strategies. Um, the more they get an opportunity to do it, the more they'll do it. What we find that parents typically give in and take over and do things for them, which
Hmm.
means less repetition, less practice, less need for them to do it.
Hmm.
So what I typically tell parents, if you're going to end up doing them, the children know that you're going to end up doing it for them. So you have
Hmm.
created this challenge for yourselves. So back
Hmm.
off.
Hmm. Okay, thank you.
Sure.
Ma'am, can I ask a question?
Absolutely.
Okay, this will be the last question. Okay, it is already 9:30, so ma'am must be tired now.
No, it's
So we
absolutely,
will
yeah.
keep it, yeah. But
Yeah.
still,
This will
we'll
be
keep
the
it
last
the
question.
last
There are
question.
some
Yeah,
questions in the chat.
yeah.
Unfortunately, we won't be able to get to those. There
Uh,
are 3 or 4 questions in the chat.
ma'am,
Yes.
ma'am, I'm the parent of 6-year-old baby,
Okay.
and also I am a first year BOT student,
Oh, okay.
and my boy has from I diagnosed from 2.5 years old.
Sorry, Anju, your voice is cracking.
Ma'am,
Yes.
ma'am, my boy has diagnosed ASD and ADHD,
Okay.
and he is taking now medication.
Okay.
Actually, in this disorder, is medication is needed, or, which help them to improve better? That's my question.
Again, it's a very A, I'm not a doctor. B, I will tell you that it's very individual, right? Some individuals with autism may still need medication as they grow up to manage their anxiety. A lot of times, even for younger kids, doctors prescribe risperidone, risdone, different versions of it to manage their behaviors. I
Okay.
don't know that that's necessarily needed in every situation when some simple strategies like sensory-based strategies, like visual schedules, like predictability can easily work in favor of some of our autistic children. But again, it's not a very clear-cut answer. It has to be based on whatever the child needs. But if it's a general tendency that a doctor is prescribing risperidone to every 3-year-old with autism, I don't think that's
Okay, ma'am. One question also. Like he is also is in diet, is like gluten free, sugar free. That is also get improve his behavior, hyperactivity, or
Have you seen an improvement?
little bit.
Okay. So by itself, it's not going to do any magic. You might
Okay.
you might see something for some time,
Uh,
but you have to follow up with strategies. You have to follow up with therapy. You have to follow up with neurodiversity of affirming approach. Visuals is something that I cannot stress on enough. You have to do other things to support
okay.
changes. That by you, it's not magic that you change the diet and autism
Uh,
will not manifest.
oh, oh, okay, ma'am. Thank you. Thank you so much.
All right.
I think we should conclude here now.
Okay.
Yeah.
Thank you so much. You've been a
Thank
wonderful audience. Everybody stayed for this long, so I really appreciate it.
so thank you. Let me thank you, ma'am. Thank you for taking out time for us, and thank you for giving such an insightful presentation. And I would like to thank all the audience for being so communicative and participating throughout the session. And I would like to thank our team OTUI also. And very good night, everyone. See
Thank
you
you.
in the next presentation.
Thank you for inviting me. See you.